Thank you so much for the invitation. I am thrilled to learn about your society and to have the opportunity to talk more about things that I'm not all that keen to talk about at work. I am actually currently employed at a naval hospital, a federal facility, and so although I have a lot of knowledge in this area, I'm not able to help my pain patients necessarily directly talking about psychedelics. So this is a thrill to be able to go through some of the research and educate you guys a little bit, and hopefully give you some thought-provoking ideas about how you can help your own pain. I am a old deadhead that took a right turn and took a left turn and wound up in nursing school, and I'm now a nurse practitioner practicing in a pain clinic. I've always had a soft spot for psychedelics for the variety of things that it's opened up for me and in my life and for others. And this is going to be an awesome talk. This is the idea of this talk is to rethink your chronic pain, and hopefully you're open to some change. Those letters after my name just basically say I'm a nurse and a psychedelic practitioner. Pain and phenomenology is an interesting way to get started with this. Anyone who's watched a football game and seen a leg snap on television, most of you will inadvertently flinch. Some of you might actually feel pain in your leg as you watch the injury occur. The mind is a complex organism. It makes sense of input, and all your senses can be fooled, sometimes empathetically, into thinking that you're hurt when you're not. There's a place called the Exploratorium in San Francisco, and you get to walk through this place that's just massive. And one exhibit in particular, you place two hands on the pipe in front of you, and you are immediately convinced that you've been horribly burned, and you let go of the pipe. And what it is one hand is got cold water running through the pipe, and the other hand has got heat running through the pipe. And the mix of those signals in your brain says you're touching something that's burning your skin. The mind, again, is just completely malleable. Some of the medicines in psychedelic realm will allow you to have a breakthrough in such a way that you can reconfigure the pain in your mind. It's a total reset of your nervous system. You can also have a total breakthrough in your mood, reduce your anxiety, your depression. One of the doctors that I follow, he uses the analogy of your car runs off the road and you're stuck in a ditch, and somebody has to come along and pull you out of the ditch so you can get driving again. And that can be in our context, that's your psychedelic, and it's going to pull you out, hopefully, of the rut that you're in, and allow you to get started down a better path for yourself. So pain, there's normal pain, right? Things that you would expect to experience. So doctor makes an incision while you're under anesthesia, you wake up, and that's going to have some lingering pain effect. You're going to have post-operative pain. People with arthritis, people who've got a disfigurement, people who experience a sports aftermath of sports injury, or even just performing sports and getting up the next day, you can feel pain from the response of your body. And I also threw on here sickle cell crisis. That is a normal sequelae of the sickle cell. A person who's got that sickle cell trait is going to feel pain when they're in crisis, and that's a normal track going up and down your from your spinal cord into your brain. The chronic pain comes in a couple of varieties. On the right hand side, you've got neuropathic conditions. Neuropathic simply refers to a squeeze of the nerve, an impingement somewhere along the line between your brain and the place that hurts. There's a pain signal that occurs, and your pain signal gets distorted. So People who have shingles will wind up with a pain syndrome while the shingles are present. And then unfortunately, a large number of those people will experience pain long after those little whelps and that rash has disappeared. That's complex post-herpetic neuralgia. Complex regional pain syndrome is someone that, again, that's a condition that you having pain signals, even though there's no particular cause. The pain that comes out of complex regional pain syndrome is something as simple as twisting your ankle and then not healing correctly. But instead of it just sort of being a passing nuisance, a lot of patients feel like they would rather have that foot amputated than live with the pain coming from complex regional pain syndrome. It is an intense, debilitating experience. Common neuropathic is distal polyneuropathy. It's probably 35% of cases, and it comes from changes in the circuitry from diabetes, uncontrolled HIV. You can have a compression of the spine that can cause neuropathic pain. And then there's all sorts of what are called central nervous disorders. So multiple sclerosis, people with a stroke, people with Parkinson's. These are conditions that cause the central nervous system, which is the area that is in your brain that leads to your spinal cord that goes back to your brain. Those get disturbed and become, for lack of a better word, they become sick or they malfunction. Then on the left, we have body-mind syndromes. And these are things that the pain is created by both your body, but is also reinforced by your mind. So anybody who continues to have pain for longer than 8 weeks after an injury, they're considered to have a chronic pain syndrome. And that is unfortunate, and that is considered to be abnormal. We expect pain. Again, we go back to nociceptive, normal pain, right? Normal trajectory of a pain of an injury is about 8 weeks. People beyond that, 12 weeks in some textbooks, will become chronic pain. Failed back syndrome refers to people who have gone in for a surgical procedure to fix their spine and come out either the same or worse off than when they went in. Irritable bowel syndrome, fibromyalgia, these are chronic pain syndromes. And these are important when we get to talking about possible ways to fix the pain. These two pathways provide the provider with information that allows you to make a choice between what kind of intervention to make, especially talking about ketamine, which is a psychedelic that we're going to get to talking about here. The dosage and the approach and the frequency will be different depending on if we're dealing with more of what we consider a psychiatric component versus a true physical lesion in the in the nervous system. So this is one of my favorite bits to throw out there. I deal in a pain clinic with, again, like I said, I'm in a naval clinic, so Marines, people who are dealing with all sorts of back injuries. One of the questionnaires that we give the patient is, what caused your pain? And I'm always shocked by the number of people that will respond to that question with the diagnosis that they read on their MRI, right? What caused your pain? My bulging disc. Well, what caused your pain? I have arthritic changes on my back. This list is the percentage of people that have no symptoms, who do not have back pain, but they, by age, this is the prevalence of the problem. So, over 50% of the Marines over 30 years old can say, well, the bulging disc or the degenerative disc caused my pain. No, that's not true. There's actually very little correlation between what your spine looks like on imaging and how much pain you'll have. People at 20 years old, their discs start to break down, right? And of course, as you would expect, discs degenerate with time. You get shorter because of gravity. You're getting, and then whatever you do on top of that, between the time that you stop growing and the time that your back starts to degenerate, there's all sorts of pressures causing those discs to degenerate. Even a full-on protrusion, you really only see that in a less than 40% of the population, right? Under 60. And so it's unlikely that the correlation is between your disc and your pain. And it's very important to realize that, because what happens is a lot of people will be brought into the doctor's office and be given this diagnosis, well, you have degenerating discs. And they'll show you a picture of a spine with with some kind of a red blip coming out of the side of it that looks very painful. But the fact is that has really very little to do with why your back hurts most of the time. 99% is the big number on this slide. Believe it or not, Americans, who make up only 4.6% of the world population, they use up 99% of the entire world's amount of Norco, of hydrocodone. There's only 1% left for everybody else. 35% of Americans, which is a good number, that's much higher than 100 million people, have one of these chronic pain conditions that we talked about. But the use of opiate is completely out of control. Even now, I mean, we keep talking about battling this, but people expect to have it. They don't want any pain ever. So they use up 99% of the Norco, and 86% of the world supply of OxyContin is also gobbled up by Americans. And unfortunately, we don't have any better control of pain than the rest of the world does, or happiness, for that matter. We really don't. We don't get bang for our buck. It doesn't control the pain. It causes other problems like craving, and a lot of times opiate will cause more pain, because once all of your opiate receptors are blocked, there's nothing for them to do. They get finished with that trick of being of the initial response, which is, wow, that made my pain better. Ultimately, what happens is, if you take opiates over a long period of time, you wind up having pain because you take an opiate, which is quite the opposite of what you were going for in the first place. So it's a very dangerous path to go down. Jumping on to how do you decide that a person has pain? Well, when we were in school back in the day, we were told that pain is the fifth vital sign, and that in addition to taking blood pressure and temperature and finding out if the patient is doing okay emotionally, that we were supposed to judge their pain. There's different scales, and most of you who have pain have probably been asked this question, or asked to rate their pain. Originally, we were taught that 1 is not very much pain, 10 is the worst pain imaginable. What's your score? But that didn't help, because it wasn't descriptive enough. And what we find with this kind of scale is, you have to sort of think about this. How is the pain impacting you functionally? There's a difference between, obviously, stubbing your toe and feeling like, your leg's being cut off without anesthesia. And even this is probably not as intense as some people experience their pain. I'm in bed, I can't move. Someone should take me to the emergency room. That's pretty bad pain. But I have people walking in with smiles on their face, giving me the score of 10 on a regular basis in my job. So sometimes the scale is a great place to start, just like maybe the MRI is a good place to start. Maybe the patient just talking is a good place to start. But putting all these together, as a clinician, you have to drill down, and you have to understand what is happening with this patient. Where is the pain? How long has it been there? How do they rate it today? How did they rate it yesterday? How have they rated it over the last bit of time? But not all of these scales are created equally. They're not all as useful as others. And that it also is in the eye of the beholder. It depends on what the clinician is trying to get to the bottom of and what the patient is trying to get across. Oftentimes you find people that have not been listened to by the time they get to the pain clinic. They've had to elevate from a 5 to a 9 just to be sure that they're being heard and understood because they've been ignored. And so you get this this creep up the scale beyond what it was intended for. So it's inexact. This is the thing that most chronic pain patients don't want to hear. And the pain is in your head. Now, it's not in and of itself, it's true. It's not meant to be an offensive statement. But again, it goes back to this idea that you're not taking me seriously. If you're telling me that the pain is my head, I feel offended. I feel not validated. I feel not heard. But the fact is, if you don't have your head, you don't have your brain, you don't have anywhere to process pain. And that is the only place that you process pain. How much pain you have is dependent on how you are wired. Quite literally, how does your system stack up to the next guy or the person next to you? The famous, I have a high pain tolerance. My 10 is someone else's 5. I hear that a lot from the Marines that I see in clinic. But we have to remember that we're processing pain through a complex system. If I do a functional MRI, which is the type of MRI that will light up your brain depending on what your stimulus is, the MRI will light up the same for a back injury, an acute injury to the spine, and a person experiencing a flare of their fibromyalgia, right? There's no difference. You can't say, oh, well, fibromyalgia is all in someone's head, right? In the offensive way. This is a construct of their mental health. No, it's going to light up on the fMRI just as much as the person who's being cut on. So it is real pain. Now, if I ask someone to lay in the fMRI and think about pain or imagine that they are in a painful situation, the areas of the brain are going to be different that light up. The imagination part of your brain is not going to be the same as the person who is truly believes that they are experiencing a pain condition. So that begs the question: how are we going to treat this pain? I like this slide. It's a good. I never know if people are looking at this on their big computer or on their small phone, but if you can see this slide, you have the pain pathways very well noted here. So TAC in your finger, right? Your nociceptors, the receptors of pain that are in the skin, are activated because you have tissue damage. The signal travels up your peripheral nerve, which is the peripheral meaning your arm, right? And it's going to head up the spinal cord to position number 3 here, which is where the chemical messengers, the neurotransmitters, are released. And those activate other nerves that then pass the information up into your brain. The thalamus is the relay station, right, in your limbic system. And they're going to relay those signals through the somatosensory cortex, which again is going to identify pain. And then the frontal cortex in your brain is where you think about things, right? That's your executive decision making. And your deep limbic system is where the emotions live. So your pain can reduce significantly just by cursing, because you are letting out some of the emotion, right? People tend to curse when they get injured, and it's been proven and documented that will decrease your pain. But the other problem with this is your pain receptor is not an island by itself. It's not just, okay, ouch. It's sending a signal that's going to imprint into your emotional limbic system. Okay, so keep that in mind. That's a very important part of how we're going to continue to build this out. Love this slide. A better, more beautiful picture of how the brain is structured here. Now, again, here's an arrow going to the deep limbic system, your thalamus. You are. This is a slide that discusses what happens when people have an ecstatic experience, whether that's seeing God, praying, meditating. That's what this is speaking to here. But your limbic system, as we just talked about, which is a place where the pain signal passes through, this is also responsible for things like that. Let me say that again. The limbic system will shut down in order to have a religious surrendering, right? It shuts down the prefrontal cortex as well, which is your executive center, which makes things make sense. And it just allows you to have this this positive or this non-physical sense of spirituality or sense of being one with God or one with the universe. Now, that's complicated, right? Because the same place that makes you feel really good, makes you feel oneness with with the love, with God, is also the place that you experience and are sure that you're having pain. So once any of these things get stuck in a position of on, it becomes bad for you. You want to be able to shift between those different states of belief, of being. And if your pain signal is so strong that it imprints on you, you're not able to do these other things that make you feel good. You wind up being stuck in a place of pain. So I think at the beginning here, Michael made the reported 80%. Up to 80%, I'm sure it's true. I'm using the 50 to 75, but we can bump that to 80. 80% of chronic pain patients are going to have co-occurring depression and anxiety, right? That's where we get back to the chronic pain problem of the body-mind syndrome. You can't have, your pain goes away in 8 weeks. You can live with that. 8 weeks is okay. That's a reasonable amount of time to recover from an injury. But having debilitating pain high on the pain scale for months and years is gonna make you anxious. Every time you move, you might have that pain. Every time you want to do something, you're going to get anxious because you could spike in pain, and not being able to do anything makes you depressed. And that is a vicious cycle to get out of, right? This next bullet on here. So when a surgeon is going to assess whether your chances of recovering from that surgery are good, bad, or equal, they like tools to evaluate those things. One study showed that patients that have 3 or more adverse childhood events would have only a 15% chance of a successful back surgery. Well, let's define adverse childhood event, right? That can be any sort of thing that you recall from a serious trauma that you experienced. Someone wronged you, something physically happened to you, something abusive happened to you, or you simply have a adverse memory of a failure or a shameful experience, something you didn't achieve, some way you were berated. That happens a lot in childhood. I mean, having 3 is really not asking much of a person. That's so, if you have ways in which your mind ruminates on a bad childhood, quote unquote, you're going in for a back surgery that you might need in order to return sensation to your foot, for instance, or return function to your foot so that you can move it. The chances of success, meaning you're going to come away from that without a chronic pain, is 15%, which is that's a tough statistic. Another thing that a surgeon will look at, and another way that we try to establish who does and does not have chronic pain or a risk for pain syndrome is pain catastrophizing. Pain catastrophizing is somebody who has had pain for so long or has created a relationship with pain that is maladaptive, such that they think all pain is bad. They demonize pain as something that they should never have to experience. Well, if you don't feel the hot stove, friends, bad things can happen to you. If you don't know you've got a tack that came through your boot, you're going to have other problems come down the line. If you don't know you broke your arm, so you see what I'm saying. Not all pain is bad. The pain feedback loop in and of itself is a good one. You want to be able to experience that. But if you've gotten to the level where you're so sick of your pain that you believe it's all horrible, that's a pain catastrophizing scale. And that means you're stuck in some sort of feedback loop that's making you miserable. And the beautiful thing about this is that psychedelics are able to remodel your belief system and get you back unstuck and on the way to feeling better. So let's get into some of this hope. We've sort of established the problem and some of the sticky points of having pain and chronic pain. What are we going to do for you? This is a fairly recent evaluation here, 2020. It's a sort of a methodology to decide who might benefit from a psychedelic. So your chronic pain patient at the top of the chart here, they've failed standard medical therapy, whatever that means. I mean, first line therapies, right? Your SSRIs, your SNRIs, antidepressant medications, pain medications, muscle relaxants, anti-inflammatories, topicals. It hasn't worked out for you. Okay, good. Next level, you're not pregnant. You do not have a significant history of psychosis or psychotic break. You don't have a cardiac history that would put you at risk for use of psychedelics, and you're not taking additional psychoactive medications. That one's a little harder because a lot of people are taking some form of medication that might eliminate them from this particular tree. But if you pass all those levels, you're a candidate for a serotonin agonist in psychedelic therapy. And then he breaks down these sort of conditions. So autoimmune response, inflammatory conditions like lupus or Behçet's or rheumatoid arthritis, a genetic disorder. This is erythromelalgia. We were talking earlier before we came on about Ehlers-Danlos, which is a connective tissue syndrome that causes severe pain. Complex regional pain syndrome we talked about. There's phantom limb pain, right? Where someone has a limb removed and then it still itches and hurts and it's actually not there. Cancer pain is often a benchmark, either from a tumor or from the removal of the tumor, or the metastatic condition that causes nociceptive pain, actually. And then your somatization or your mind-body syndromes like fibromyalgia. There's also people who develop a syndrome around TMJ or temporal mandibular joint syndrome. Those people, according to the study, respond well to psychedelic medicine. Well, what does that mean? What is psychedelic medicine? Love this statement. It was made in 1980, a quote from Dr. Stanislav Grof. Quote, "It does not seem to be an exaggeration to say that psychedelics, used responsibly and with proper caution, would be for psychiatry what the microscope is for biology and for medicine, or the telescope is for astronomy. These tools make it possible to study important processes that under normal circumstances are not available for direct observation." So it's a brilliant tool, and it gets down to the crux of the problem, hopefully, that people with pain are suffering from. Psychedelic means soul manifesting. or mind manifesting, from the Greek, and you can read the words there, Delosi, Pishi and Delosi, soul manifesting. Psychedelic experiences reveal striking but previously unknown or rarely felt states of mind. Psychedelic actually comes from Humphrey Osmond, who is a psychiatrist in Canada, and his exchanges with Aldous Huxley, the famous author, around 1953. He had a mescaline experience, and they came up with the term, actually, psychedelic, before he wrote Doors of Perception. The new sort of in vogue term is entheogen, which means the God within. Okay, so those are how we're calling these substances that are going to help people get out of their ruts, out of their stuck states of mind. Things such as synesthesia and feelings of euphoria, love, trance, those are all things that can happen. But on the flip side, psychedelics are also very well known for having unpleasant and frightening, intense experiences. Synesthesia, by the way, for those who don't know, it's two or more senses experienced separately that are suddenly felt together. So, you know, Monday and red, or music and flavor, things like that. Challenging experiences can be handled. They can also be very well illustrative for the patient if they're willing to lean into that bad experience and they have a way to work through it with their therapist. They can make a huge breakthrough. They're not always to be feared or shunned, or the tendency is to let's get that poor soul some Ativan or some Valium so that they can stop having this horrible experience, and that's sometimes counterproductive. Even though we're hoping for good things, when bad things happen, it can be very helpful. And one of the ways to obviously control that response is to make sure that you have a set and a setting that are conducive to your healing. Set is going to include your internal psychological variables, suggestibility, preparation, that you have intentions going in, while setting is going to refer to your environment, right? It's where you're going to experience the medicine. But the setting also includes things that you have less control of, like your, where you are socially or culturally in context, what the interpersonal relationship is with the person in the room with you. So a new user, their setting can be that they're anxious or they become immediately disoriented. An experienced user, their setting is just going to go straight to the euphoria. And that's very important when selecting the amount of ketamine to start with as well. A person who's had a good experience, they want to get to the high state, the breakthrough sooner. So you'll give them a larger dose than someone who is wary or has had a bad experience in the past. 9 core criteria of the psychedelic experience. You can read these off, but essentially this goes back to Walter Pahnke and the Good Friday experiment. He was attempting to understand what a divine experience is, and so they decided to define it. As scientists are wont to do, they define things, and so you have these experiences here are considered criteria for psychedelia. All good things. Don't think anyone would argue with that. The differences among the psychedelics: first, we have the classics. This is probably preaching to the choir with most of you, but we'll go through this real quickly. LSD, psilocybin. DMT is a tryptamine found in ayahuasca plant mixture, and mescaline comes from peyote buttons, originally derived from a cactus, but they can be synthesized in a lab, as can all of these. And then the non-classics, you have MDMA, which is a different molecule altogether, and been around since 1912, actually. And then ketamine, which is a dissociative anesthetic. By its classification, people talked about walking in outer space. It was initially used only in veterinary medicine, became approved for humans some 50 something years ago, and is now widely used, and the only one that we can actually prescribe to you currently legally as providers. Back to this concept, straight to your head. 1963 to 1967, the psychiatrist Aric was looking at cancer patients and pain response. Demerol, 2 hours of pain relief. Dilaudid, which some of you may have had, that is good for about 3 hours. LSD, when administered in the setting of helping cancer patients with their pain that they were reporting, 92 hours up to 10 days, right? Now, the treatment, as it turns out, when they look back at this, probably was more affecting the existential suffering than an analgesia per se, not like take an aspirin and call me in the morning kind of thing. But patients responded to having those peak experiences, and it resolved some of their fears. Patients were much more comfortable saying, I need a pill, I have pain, my stomach hurts, I'm in terrible pain, than they were less comfortable saying, Doc, I'm terrified to die. And so you see that this was able to put their pain in perspective for them, and their existential angst. Recent literature showed that microdosing LSD might have some benefit for pain relief, but it's the studies are still not great. It's hard to have a placebo. It's hard to study, but it looks promising that that we might have some pain relief. Ketamine, I can tell you for sure does. I prescribe it daily almost. It's a Schedule III drug. It's not Schedule I, which means it's not illegal to talk about or to use. It's currently used for therapy and antidepressants in small doses, which means about 0.5 milligrams per kilogram. And these are IM or IV doses here. Psychedelic effects take place when you get it more like 0.6, 0.7 to 1. And then this was traditionally used as an anesthetic, right? This is a medicine that was used to get injured people off the battlefield and take them out, or to put them under for dissociate them from their consciousness for surgical procedures. So at a high dose, you're out. You don't know anything. It's a potent NMDA receptor antagonist, which is the receptor that's responsible for central sensitization, like we talked about before, the people with post-stroke or other conditions that are causing a wind-up effect in the brain. It's possible that ketamine is also acting on cannabinoid receptors, which is an interesting whole other talk. We can talk about just using cannabis for pain and why it works, and whether or not that's a psychedelic is another whole can of worms, but it's a good medicine for pain patients. Ketamine, unfortunately, can cause all sorts of havoc. It can change your heart rate. It can put you out of sustained rhythm, increase or decrease your blood pressure. There's something called ketamine bladder or ketamine cystitis, which is, you'd have to use a lot of ketamine. I mean, these are, you find these conditions out because people were abusing the medicine and taking it daily in the realm of, hundreds of milligrams a day. Those people were addicted. They were, using it as a club drug. They coined the term ketamine bladder. But even at low doses, you can have some bladder irritation and find that you really want to get up and use the bathroom, or that your bladder hurts when you do urinate. But it's transitory. It usually departs in about a day. But the good point is it can really help, and we need to be clear about how we can use this medicine going forward. It's taking off. You can see ketamine clinics popping up everywhere. Not everyone does it well. Some clinics don't even have a therapist. They're just an anesthesiologist who want to give you some ketamine to make you feel better. But one of the things to keep in mind about psychedelics is you can have these brilliant experiences, and ketamine studies have shown that you actually can sprout dendritic growth in the brain. I mean, you're literally creating new connections. But if you're not able to sit and reinforce those with somebody and work through what it brings to light, it's transient. Those dendrites will die straight away, and not form any lasting change for you. So the idea of popping into a ketamine clinic and popping out and being all better is it's not a quick fix. Psychedelics for recreation is one whole use, and there's pros and cons to that. But thinking that jumping through an LSD trip and then having your life line up and your pain go away and everything being exactly perfect is unlikely. We want to emphasize that it's the psychedelic assisted therapy part that is of benefit here, or the ketamine assisted therapy part. The default mode network is the much talked about portions of the brain that connect to each other, and they cause you to have a way of looking at the world. And sometimes that can be great. That is your touch point to make sure that you understand reality. But in some cases, it is also overweighted with a response to adversive experiences that have caused you to have erroneous beliefs about reality and the world. And because you are in this default, you are ruminating on your pain, for instance, or your sadness or your trauma, and this weighs you down in ways that are that become maladaptive. So, what a psychedelic is going to do is it's going to break you out of that. Carhart Harris has come up with a term called REBUS, which is an acronym, REBUS, REBUS, and that is standing for Relaxed Beliefs Under Psychedelics. And so what happens is you're basically breaking out. You're like we said earlier in the talk, you're stuck in a ditch and the tow truck is coming and it's going to pull you out and get you back on the road. Psychedelics are allowing you to have that breakthrough and shake up that default mode network so that your brain is going to look more like this. On the left, you've got the normal state of connectivity. And sometimes we can think of this as, there's a couple of metaphors here that I like. One is, remember when we used to be able to fly around America, fly around and see things? This is sort of your basic, local airline flying between Denver and Chicago. You've got a couple of little routes going on here, but you really can only go a few places. There's not a whole lot of exploring going on. This is more like your global carrier with all of your partners. You can go everywhere. You can see everything. And this is your brain on drugs. It's not a frying pan with an egg. It's actually this amazing spirograph kind of image of possibilities. Things go from sort of a rut, a connection, to, hey, wait, let's rethink this. Let's think about this. Another way I like to think about this is sort of your snow globe at rest, and this is the snow globe after you've shaken it up and things have taken off and all sorts of new possibilities come to mind. You break out of your default mode of the way of thinking about your pain condition or your suffering, and you come up with new possibilities and new ways of experiencing yourself and your place in the world. And that, with that, I also wanted to just throw out there, there is a new study, University of California at San Francisco is enrolling patients now for a look at low back pain and psilocybin. And so we're hammering this out. We are well on our way to making the leap of the anecdotal evidence that we have from the 60s that psychedelics do improve pain. They're trying to now, of course, as scientists do, as I said before, they want to prove it. But I think just anecdotally, we have plenty of, I have personally plenty of faith that this is something you should explore if you're stuck. As soon as you're able to meet with a therapist and find a way to afford it, I think starting with ketamine, as we wait for these other drugs in the pipeline to come down to a legal status, ketamine is a great way forward. It will shake things up. And if you have tried therapy, cognitive behavioral therapy, or another form of therapy, and you've gotten to a place of feeling like you can't go anywhere with it, or you're frustrated, find someone who will help you take some ketamine and then have therapy and see what happens. So that's my talk. Keep in touch. I have a website under construction, the psychedelicnp.com, where there will be more educational opportunities, more talks, break down the different medicines, how they work, where they're available, what's happening. You can email me, psychedelic.practitioner@gmail.com. I'm on Twitter, Instagram. We can put those in the chat, but let me stop sharing my screen. And we can tell me what's happening.
All right. Okay, very good. Thank you very much. That was super informative. Definitely a lot to think about and digest. Thank you very much. That was a great talk. And
Pleasure.
we'll definitely put those links in the chat if you can either give that to one of us or just put them in the chat box there if you can.
Sure, I can do that.
So yeah, it's wonderful that you're willing to share your time and your knowledge and expertise, and hopefully people are helped in some way. And
I hope.
so, yeah, totally. I don't see any questions per se. Alan has other routes of administration for ketamine: nasal spray, lozenges, suppositories.
Yes. So the nasal spray is the approved route, right? That's going to be approved by many insurances now are going to allow you to use that medicine as a covered benefit. And the nasal spray is dosed completely differently than IV or intramuscular. But the recommendations currently are to go ahead with a larger or more sizable dosing to get you on stock, and that will take several times in the clinic, probably 2 or 3 sessions a week for several weeks, and then the lozenges. The oral bioavailability is poor, so they're variable. You get them compounded, but they can be enough to extend your experience and help you work on those. Like we said, those dendritic growths, those positive thoughts. Can be reinforced with lozenges or the nasal spray. I know of some patients that are doing well with the nasal spray for migraines. As well as for their mental health. So that stuff is, again, widely available. You can look around for a doc that's willing to help you out with that.
Cool. Yeah, I know you talked about it breaking people out of catastrophizing. That was definitely really my worst symptom that I had, that psychedelics helped me with, was just catastrophizing constantly and just nonstop, and I had no control over it. So yeah, as far as psychedelics go, have you seen any studies perhaps showing differences between the different types of pain that you describe, like the mind-body syndrome, neuropathic pain, CNS disorder pain, or is it all kind of similar as far as pain relief from psychedelics goes?
So the ketamine is known to, for instance, is most known for helping with neuropathic pains, and the most widely studied is the chronic regional pain syndrome. But the mechanism, it depends on your mechanism of injury and where your lesion is and why you hurt. And the emotional suffering part, the attachment to the pain. What I tell a lot of people, and again, we kind of got at this, but just to say it more directly, especially when I'm talking to someone who's been in battle, it's much easier to talk about how much your back hurts than it is to come to terms with what happened to you out there. Watching people, losing people in front of your eyes, being traumatized, blocked memories, things like that. So you can have a breakthrough and get rid of some of the pain that you're experiencing that is psychological pain, that you are using the physical manifestations to not deal with that's Dr. John Sarno's sort of take on things, right? The other conditions that you're talking about, the specific mechanics of a mechanism of injury or a mechanism of pain, the true analgesia. So we know that most of the psychedelics are working on the serotonin pathway, and by either flooding the mind or the body with serotonin or blocking it, depending, you're affecting, you're freeing the brain a little bit and you're freeing the mind. But where the analgesia is actually taking place is still a little bit unclear.
Cool. Thank
so
you
that, yeah, that's my best answer there.
Let's see. Valerie, you have a question? You want to unmute yourself here? Just hit, there you go. Hi.
Hi, and thank you very much. It was very informative. I do have just a question. I have never used any psychedelics in any way. A brief history, I'm looking at some different kinds of autoimmune issues that I'm having, SI joint problems, and just overall chronic joint problems, and a few other things. But one of the things that I was concerned about is I have what they call white matter around the ventricles of my brain. So I don't know, do you have any idea whether that would be something that would preclude me from trying any of these things, or would my neurologist be able to talk about this with me, or?
Yeah, I think as this become, as the question arises more, with medical professionals, they're getting, the ones that are sort of anti or scoff or roll their eyes are going to have to get online, because this is coming and it's going to be a modality. They're going to get the question, and dismissing it out of hand because of Timothy Leary is incorrect. It's a bad way to go. We all have sort of a taste in our mouth from that, or those of us who are old enough to know or have been taught by our government that that the psychedelics are horrible and dangerous and poor for you. That's not the case anymore. I think with that said, though, I will say also that while the compounds are being studied at a mad racing tempo, they are doing a very thorough job of ruling out risky patients, right? So some of that is, I guess, to be expected, but some of it's unfortunate. And I think the answer to your question is we don't really know where the dangers lie. I can speak to the questions of ketamine because I've seen people, need a code cart based on underlying cardiac conditions. But as far as some white matter in the brain precluding you from taking something, I don't think that there's no evidence that it's going to cause a neurologic issue. And in fact, what they're studying in England, in the UK, is there's a stroke protocol, right, where you get someone to the hospital as soon as possible and try to do some clot busting. Well, they're also finding in experiments that oddly enough, dosing someone with DMT at the time of stroke is shown to protect them to some extent from memory loss and function loss. So it might be quite the opposite. It might be that this would help you. It just sort of depends on your neurologist's take, especially if it's if sometimes brain scans, you find all sorts of sort of random findings. But did he tell you that there was a diagnosis or a danger regarding these findings on your scan?
The only thing they found is that it is increasing, and that it could lead to some symptoms of difficulty walking and that sort of thing.
I see.
So
I see.
Kind of an ongoing study, I guess.
Gotcha. Well, if you can find a way to, so you're really trying to treat your pain or your anxiety, discomfort?
Pain and anxiety, right?
Okay. Yeah. So at this point, your best bet again, especially if you're insured or if you have money to spare, is to try to find a ketamine clinic close to you, or look for a provider that's sympathetic to your condition and see if you can work with them. And then always let your other providers know, if you're under the care of that neurologist, that this is what you wanted to try.
Mm-hmm. Ketamine versus psilocybin would be better.
Only because you can be supervised legally. But do I think personally about psilocybin? I'm not sure. I think there's a lot to be said for sort of. Do I mean, I'm sorry if you don't mind me asking, do you have a therapist that you like and that you trust?
No.
Okay. So maybe, the first step, I think, is to establish care with somebody. Some people will do what's called integration post psychedelic with you. So you've done something on your own time because you decided you wanted to, and then work that experience through with the therapist. Now, of course, if you're totally psychedelic naive, you want to make sure that that's you want to check your dosing and check your source and all that stuff. But I think it can be helpful for you.
Okay. All right. Thank you.
Well, there's two questions here, or there was. I guess looks like the hand we had raised is not raised anymore.
Blaine had a question.
Oh, Blaine. Okay. Or
Let
Jonathan.
me get to it. What are your thoughts on macro dosing versus micro for pain, if you have any experience with both?
Again, I think it kind of goes back to that. What is your intention going in? What is the goal of the journey? I don't know that micro dosing was going to have all that much of an effect. I mean, there's people who do that, and certainly take
We froze up there again. We'll wait just a minute here.
see yet.
Now we can hear
Now
you.
you're back.
I think the macro dose, or the larger dose is going to get you farther faster, and then reinforce that with your, what did you learn and why did it help, and because again, it's all being processed up here, regardless of the input of your body and what your condition is. It's making friends with that pain. I always tell the Marines, I can't, on the pain scale here, we can't promise you the 0. You're not going to be the happy face. It's just not going to happen while you're in the Marine Corps carrying a guy on your back for a test every once in a while. With a bad back, you can't get to 0. So be realistic with yourself and set those goals going into the journey, to the experience. And once you're there, and have the larger blowout of the cobwebs and the stuckness, I do think that it follows that following that up with an occasional microdose would be useful for you.
Cool,
And
thank you.
Blaine, I didn't mean to put words, I didn't mean to read, you're perfectly capable of talking. You have a take on microdosing and macrodosing together that I think is useful for other people to hear if you're willing to share.
Oh, I'm thinking that I'm just going to let Aric talk. This is just a great presentation, but thanks, John.
Okay. And I had a question, Aric, just quickly. Multiple sessions per week over multiple weeks can get really expensive. What's your experience relative to the acceptance of insurance companies to actually doing this?
So that's it's kind of a crazy thing. I mean, I work in a weird world, with TRICARE not really caring what we do with the active duty members. I can say that there are patients in Colorado that I'm aware of who have Medicaid who are being supported in the quest using the medicine, and then other people are just it does get spendy, but it may be, it just depends on, can you put a price on something that's going to make you feel better? I mean, it depends on your ability to work with the group and that you're approaching, and whether they can help you out if it comes to expensive repeated sessions. But you kind of got to brace yourself going in that the cost is going to be out-of-pocket cost is going to be kind of hefty for ketamine. Although, as I don't know if you follow Rick Doblin much in the MAPS thing, but trying to get the VA on board, with some of these cases, because they're showing that MDMA is going to, knock it out of the park as far as breaking the PTSD cycle. But the VA scoffs because, you're looking at a $30,000 treatment, right? But $30,000 treatment versus paying a guy for the rest of his living days to live with PTSD and not be functional and not do anything. I think that it's always a question of the cost benefit analysis. But as these companies are paying for the nasal spray, I think they're going to keep pushing the envelope a little bit. And if you can show benefit, you wind up showing that insurance should cover it.
Cool. Andrew has his hand up and had a question, and then I see Mike asked a question in the chat box. So Andrew, you want to go first here?
Yeah. Hey, Aric, thanks for the talk here. Fellow nurse, so this is actually coming from my experience as being bedside nursing, kind of right in the hospital. Kind of a two-part question. I've worked on both neuroscience units and seen a lot of people with back surgeries and different things like that. But one of the recent units that I worked on was actually in a ski town, so they did a lot of ortho surgeries, hips and knees and things like that. But they had such a good program of pre-education before the surgeries actually happened. And I was wondering if you'd seen any research on how effective that sort of setting up expectations and just getting the patient really primed for what the plan is going to be post-operatively and reductions in pain. And then if that's true, do you see using psychedelics as almost like a prophylactic for people going into pretty high-rated pain surgeries, like maybe back surgeries and different things like that, coming down the line once this is fully acknowledged and accepted, which I expect to happen soon? Yeah,
that's interesting. I mean, just based on what we present here, what we talked about, how we process this in the deep in the limbic, I think priming them. I think right now you as a patient going in, what is your experience? Sign here, absolve me if I screw this up. good luck. We'll do our best to handle your pain, but if it gets bad, we'll send you to a pain specialist to, wash our hands of it. I mean, I think if you have a good team involved that's going to prime you for a positive, and that could include, I know that there's studies that show that using gabapentin preoperatively can reduce the post-op neuropathic pain because you're already sort of pre-treating the pathway, right? So it would follow that I think a psychedelic approach to that would also decrease the anxiety around the possibilities of it being a bad experience. And then having almost it's sort of like having a psychologist in your pain clinic. You need to sort of prime the pump a little bit, and I don't think we do that very well. But the possibilities for
Lost again there. Still frozen there.
using to have
There we go.
Oh, am I gone again? I'm sorry.
You were gone again. Yeah, possibilities for it's where you left off.
Possibilities of utilizing this. Some of my favorite studies are the ones where they're studying the healthy normals, right? People without the mental health disorder. They're just looking at how it affects the person, and the robust response to creativity, to response to music making, to the general well-being, overall feeling well. I think if you take that data into consideration and use that as a pre-op sort of launch, I mean, I think that's a brilliant idea, Andrew. I think that would absolutely work. I don't see why it wouldn't.
Cool. So Mike has a question. Are there any risks with macrodosing while also taking prescription pain medications such as Vicodin? We kind of always have questions of this that go around just about every meeting. So what's your take on that?
Trying to go back through my Rolodex and think if there's anything that I looked at about the opiate. The opiates are really blocking the mu receptors. So if you're, I don't know that. I know that there's a lot of question about the SSRIs, the SNRIs, anything that's working on the serotonin pathway. Epinephrine, norepinephrine pathways are going to be problematic. Potentially because of you're going to reduce the effect of the opiate. I mean of the psychedelic. The opiate, I really don't know. I can't think of why that would be interacting. What do other speakers
The only
say?
one I really know of is like tramadol because it has like SSRI type effect. You can have potential for serotonin syndrome on high doses of both, but I think it would take an awful lot to get to that place with that even then.
Yeah, you'd have to eat a lot of tramadol for that. Yeah.
Benzodiazepines can also interfere. They won't necessarily cause harm, but my understanding is that they can definitely temper or tamp down the experience of many psychedelics.
True.
Anecdotally, my experience, I'm a longtime RA sufferer, and I'm on a regimen of opiates still to this day, and I found no issues macrodosing or microdosing while also taking my regular regimen of opiates. So.
Cool.
But
someone has a question here. Ketamine and opiates. What's your take on that?
Again, let's see. Well, let's see. It's an NMDA receptor antagonist. I mean, so one of the talks that I recently attended, the guy said that ketamine is is the only medicine he's come across that can reverse opiate-induced hyperalgesia. Now, having said that, I know that when there's a way to block the dissociative effect, but it does not block the anesthesia effect of ketamine. but I can't think of the, again, we're talking about very specific, the mu receptor of the Vicodin or the oxycodone or the morphine. I don't see how those two things are going to be bad together either. Normally, you screen the patient obviously for whatever they're on. Ketamine's a little bit more forgiving interaction wise. Although I believe might go through CYP 450, I can't remember. But anyway, I don't see a problem just straight out of hand.
Cool, great. Thank you very much. And yeah, Robert had just a question. Should I cleanse or detox prior to psychedelics? Do you have an opinion on that, Aric, or does someone else have an opinion on that? What the best way to go about that is?
So there's actually, if you're familiar with ayahuasca, I think that there's a ceremonial aspect to any of these that if we think about where this all came from, right? The prehistoric use, shamanic use of these substances, it was always about a cleanse. It was always about a reset, and that. So if you're so for instance, the ayahuasca ceremony, there's a very strict diet prior to, for 5 to 7 days prior that you eat, and then the no food beforehand. I think getting off of your medications, obviously always dangerous, always a question, always want to do that with the person that prescribed them to you. But the more, how do you want to say it, the blanker the slate is, that's poor English, but the better your absorption and your breakthrough is going to be. I'm a huge fan of this, bringing some ceremonial, some sacred to the process prior to ingesting, or even before you come to a ketamine treatment. I mean, we make them no food by mouth 6 hours before, just because we don't want them to be nauseous or vomit. But honestly, the residual of that is the ritual of being open to the experience has to do with having a clean vessel to start with.
Cool, thank you. Yeah, and Robert also asked mushrooms and opiates. John said he doesn't have any problem with it. I haven't had any problems with it in my experience either. But Aric, do you have any thoughts, or have you read anything? Mushrooms and opiates having any negative effects? Okay.
No, you're always worried a little bit about CNS depression. I guess it depends on how much of each one. If you're on a large dose of either, it's always going to be a little questionable about how that all plays out in the brain. But no, I wouldn't think that there's any strict interaction that I've read about.
Okay. Robert, did you have something to add? You had your hand up there. No? Okay. All right. We're at 7:26. Does anyone have any further questions? Donna?
Yes, thank you very much for the talk and for seeing everybody tonight.
Pleasure.
I just wanted to know, you mentioned a study in San Francisco on microdosing, I think, and back pain, or at least psilocybin and back pain. Do you have specifics on how I can find that study?
So that's just hot off the press. That's a faculty member named Andrew Penn, who's also a nurse. He pinged me as I told him I was getting ready for this talk, and said, make sure everybody looks out for the study. We'll be enrolling soon, looking at back pain and psilocybin. So keep your eye out.
Where would you go to look for such studies? If just
That's a great question. there is maps is your best resource always for those things. What are the active, what are the active studies? What's coming up? What's coming down the pipe? What's been completed? What are the outcomes? I mean, they're just so ridiculously thorough in this realm. But I should know. I should be able to rattle off the one that's the active studies, but I don't know it.
Cool. Yeah, I'm sure Maps is pretty good about that kind of stuff. And yeah, I just didn't know if you had a secret website for signing up people for psychedelic studies.
No.
But okay, cool. So we've got our other addresses and different things in the chat box here for everybody. So thank you again very much, Aric. We really appreciate you taking time to put this together. I mean, that was a great, really informative talk and really well done. And thank you everybody else for attending and for your wonderful questions.